Greetings everyone. Welcome to the presentation of the research titled A Detailed Study of Ethical and Social Views and Potential Harms of AI Applications in Oncology. I am Anik Dey from Bangladesh, currently a high schooler and the founding president of a research organization named UGEN. Our research disclosures are as follows. A short introduction to AI, its applications in oncology, the ethical, legal and social implications and rising risks regarding the subject, and discussing some probable ways to tackle the challenges. Now, what is AI? AI refers to the ability of a machine performing tasks associated with human intelligent behavior. Healthcare fields, including oncology, are seeing a notable rise in AI-based startups. In 2019, $4 billion were invested in AI-based healthcare startups in USA. Now, the multidimensional applications of AI in oncology extend to measuring risks, prognostication, clinical decisions, management, and developing cancer drugs. But are we only getting the benefits? No. Our research highlighted the potential risks regarding the implementation of AI in oncology, including algorithm values, bias, poor data quality, and data protection. Our research method covered 4 steps. We interviewed patients from 6 different communities. We also interviewed medical professionals, AI entrepreneurs, collected medical reports, and conducted a broad systematic review of multiple databases. The first case which got highlighted in our research is the undiscerned values encoded in AI algorithms. Though we claim AI is value neutral, it is not. AI algorithms inevitably encode values which are hard to determine. For example, a breast screening program may prioritize false negatives over false positives. Also, the black box problem AI introduces is the interpretability problem. We often cannot explain how an AI system is using a data and how did it give a certain decision. These undiscerned values lead to critical outcomes for patients and bias. Currently, we evaluate AI performances by accuracy rather than effective outcomes. This creates a rush in AI implementations with less clinical trials, affecting patients' trust in clinicians and lastly increasing the chance of overdiagnosis. While AI models are fully dependent on data, the data qualities leave a big concern. A recent study by Michigan Medical Center depicted that at an ophthalmology clinic, only 23.5% patient reports matched with electronic health records data, which are used in training AI models. Moreover, most of the AI models are trained with disproportionately huge amount of bad data, like a breast screening program getting trained with mammograms of 1,000 women, where only 0.5% had breast cancer. These errors and discrepancies in data lead to wrong AI decisions. There is now extensive evidences from fields including higher education, finance and criminal sentencing that feeding biased data into AI systems produces systematically biased outputs. World's one of the largest multi-technology company, Amazon, stopped using a hiring algorithm after discovering its bias towards men. Also, flawed data sampling is another source of bias, where some communities are under or overrepresented. Transferability is also a significant issue for AI. High-performing algorithms commonly fail when transferred to different settings. Data ownership and privacy are critical issues too in oncology field. Recently, the Italian government released to IBM Watson the anonymous health records of all 61 million Italians without individual consent from patients. Such releases raise significant concerns regarding what economic goods should be required in exchange for provision of these valuable datasets. Also, expansion of data leaves the risk of data leakage. And when clinicians become AI system dependent, patients not sharing data do not receive proper treatment. Figure 3 and 4 demonstrate the average health breach in USA and the number of individuals affected by the incidents in the timeline of 2009 to 2019. Currently, there are no legal regulations regarding responsibilities for wrong AI decisions. This is referred by the term regulatory vacuum. Virtually no courts have developed standards specifically addressing who should be held legally responsible if an AI system causes harm. The recommendations that we can make are prohibiting non-explainable algorithms, not implementing AI directly to clinical practices, rather only in research settings, assuring transparency in all data by verifying data sources and external validation, conducting community-based participatory researches to minimize bias, ensure public engagement and proactive government and regulators' role, managing commercial interest conflicts among different industries, and attributing responsibilities to healthcare workers regarding AI decisions. To gain out the maximum benefits of AI practices in oncology, we at first need to address it as a social challenge rather than a technical challenge. Then, following some proper steps, including discerning algorithm values, their explanations, assuring transparency in data, may redirect the AI applications in oncology and bring out our expected results. So, thank you for listening. Any questions?